Welcome back, everyone, to another neurovascular nugget. Today, Salma, we're diving into something truly crucial, a recent review that really sharpens our focus on mechanical cervicocerebral circulatory disorders, but with a twist, in children. It's an area where the pediatric landscape is frankly quite different from what we typically see in adults, and understanding these nuances is absolutely paramount for our younger patients.
Prof. Mansoor, I'm really looking forward to this. When we talk about circulatory disorders, especially those affecting the brain, my mind often goes straight to adults, atherosclerosis, age-related issues. But children, that immediately flags it as a whole different ballgame. What are some of these primary differences we're talking about?
Excellent question, Salma, and it's precisely where this review shines. Let's take Bow-Hunter syndrome as our first example. In adults, we often associate it with the lower cervical spine, typically C5, C6, C6, C7, often secondary to spondylosis, degenerative changes. But in children, this review emphasizes that it primarily involves the upper cervical spine, C1, C2, and we're talking about vertebral artery dissection. That's a huge distinction right there. Different anatomy, different pathology. It's not about wear and tear, it's often something more inherent or acute.
So for kids, it's C1, C2, and dissection is the culprit, not just compression from something like bone spurs. That's quite a shift in focus. And I imagine the implications for treatment and prognosis would be vastly different too, especially since children are still developing.
Exactly. This is where it gets really impactful. The review strongly highlights that Bow-Hunter syndrome is a major cause of posterior circulation stroke in children. Think about that. A potentially preventable cause of stroke in kids. And here's the kicker. For diagnosis, we absolutely need catheter angiography, often with head rotations, to really see the dynamic compression or dissection in action. This isn't something you can reliably catch with just static imaging.
Catheter angiography with head rotations. So we're essentially recreating the movement that causes the symptoms to truly capture the issue. That makes a lot of sense. But if it's a major cause of stroke, what's the urgency like? Are we talking about a condition that often gets missed or perhaps misdiagnosed initially?
I think it can certainly be missed, or the full picture isn't always appreciated immediately, and the urgency is extreme. The review points to a study by Rollins et al., which found an astonishing 80% recurrence rate of stroke with medical management alone in pediatric Bow-Hunter syndrome. 80%. Compare that to adults where medical management often has a much lower recurrence rate. This stark difference unequivocally highlights the need for definitive surgical treatment in pediatric cases. We can't just manage these kids medically and hope for the best. It's simply not good enough.
Wow, 80% recurrence is terrifying. That completely shifts the treatment paradigm from what we might consider for an adult. It's a call to action, really, for surgeons and neurologists specializing in pediatrics to be highly aggressive with diagnosis and intervention. So, surgical management, what does that typically entail for a C1, C2 vertebral artery dissection?
It can range from decompression of the vertebral artery, freeing it from any impingement by bone or fibrous bands, to fusion if there's significant instability, or even bypass procedures in more complex cases. The key is to eliminate the dynamic compression or the source of dissection. But the core message is that observation or simple antiplatelet therapy, which might suffice for some adult cases, is simply inadequate for these children. We're talking about preventing a lifetime of disability from recurrent strokes.
It makes perfect sense. And you mentioned other conditions as well. What about Eagle syndrome? That's another mechanical compression syndrome, typically of the internal carotid artery, right?
Yes, exactly. Eagle syndrome, where an elongated styloid process or calcified stylohyoid ligament can compress surrounding structures. Now, this review emphasizes that symptomatic internal carotid artery compression or dissection due to Eagle syndrome is exceedingly rare in children compared to adults. Extremely rare. So while we keep it in mind, it's not the primary concern we might have in an adult presenting with similar symptoms. However, the diagnostic principles like provocative vascular imaging and the surgical treatment approaches, if needed, are quite similar to adults.
Okay, so bow hunters is more common and aggressive in kids, while eagles is much rarer. That's a good distinction to keep straight. It sounds like the review is really about fine-tuning our differential diagnoses based on age. Are there any other emerging areas in pediatric neurovascular mechanical issues?
Absolutely, Salma. And this is another fascinating and evolving area: symptomatic jugular venous compression. For years, the conventional wisdom was that venous drainage shouldn't be posture dependent, that it's robust and flexible. but growing evidence indicates that symptomatic jugular venous compression can indeed occur in children, leading to symptoms like headaches or cognitive issues. The review suggests this entity is likely significantly underdiagnosed right now.
Jugular venous compression in children? That's intriguing. I mean, we're taught to think of venous systems as quite forgiving. What would cause that in a child, and how would you even diagnose something so subtle, potentially presenting with vague symptoms like headaches or brain fog?
That's precisely the challenge and where the diagnosis gets clever. The key, according to the review, is dynamic venography. We're looking for reversible flow changes or elevated pressure gradients with head positioning. So much like with arterial issues, you have to provoke the situation to see the problem. If a child has a persistent headache that varies with head position or subtle cognitive changes, and we've ruled out other common causes, jugular venous compression needs to be on our radar.
Dynamic venography. So again, it's about seeing it in motion. That's a recurring theme here, isn't it? These aren't static problems. And the idea that venous drainage can be posture dependent, especially in children, really challenges some long held beliefs. Could anatomical variance play a role here too, perhaps more so in children?
You're absolutely on the right track, Salma. The review explicitly points out that bony anatomical variants in children likely increase their risk for developing these disorders compared to adults. Children's skulls and cervical spines are still forming, still have different proportions and sometimes unique variations that can predispose them. So recognition of high-risk anatomy on CT or MRI is incredibly important. A subtle variant that might be asymptomatic in an adult could be a significant problem for a child's developing vascular system.
So, when we're reviewing imaging for a child with these types of symptoms, it's not just looking for overt pathology, but also subtle anatomical differences that could be predisposing factors. That's a crucial takeaway for radiologists and clinicians alike. It means we have to really sharpen our interpretive skills specifically for the pediatric population rather than just extrapolating from adult experience.
Precisely. And to bring it all back to a fundamental diagnostic principle, despite all the advancements in non-invasive imaging, the review strongly emphasizes that catheter angiography remains the gold standard for diagnosis of these arterial disorders. It provides the best combination of dynamic information and anatomical detail, especially with head provocation maneuvers. For venous issues, dynamic venography, as we discussed, takes center stage.
So even with MRA and CTA, the dynamic information from catheter angiography is irreplaceable for these specific mechanical compression syndromes. It's about seeing the actual impingement in real time under stress. That's invaluable, especially when surgical intervention is on the table.
Exactly, because when you're considering surgery, you need to be absolutely certain of the diagnosis and the exact point of compression or dissection. It's not just about identifying the problem, but localizing it precisely to guide the surgeon. The beauty of this paper really is how it crystallizes the differences. It moves us away from a one-size-fits-all approach and truly allows us to tailor our understanding and management to children.
And that's so vital, isn't it? Children aren't just small adults. Their physiology, their anatomy, their disease patterns, they're all unique. This review really drives home that point for these cervicocerebral circulatory disorders. It feels like a wake-up call for anyone involved in pediatric neurocare.
It truly is. The implications are significant. Improved understanding means earlier recognition. Earlier recognition leads to appropriate diagnosis using the right tools like dynamic angiography. An appropriate diagnosis guides timely and definitive management, particularly surgical intervention when necessary, thereby preventing recurrent strokes and long-term neurological deficits in children. It's about preserving their future.
That's a powerful message, Prof. Mansoor. So, to summarize for our listeners, pediatric mechanical cervicocerebral circulatory disorders, especially Bow-Hunter syndrome and potentially jugular venous compression, are distinct from adult presentations. High index of suspicion is key, especially for upper cervical spine involvement and vertebral artery dissection in children with posterior circulation stroke. And definitive diagnosis often requires dynamic imaging, with catheter angiography being the gold standard for arterial issues and aggressive surgical management often being necessary for conditions like pediatric Bow-Hunter syndrome due to high recurrence rates.
Couldn't have said it better myself, Salma. This review really arms us with the knowledge to make better, more informed decisions for our youngest patients. It's a testament to the ongoing advancements in understanding neurovascular pathology. A huge thank you to the authors for this incredibly insightful piece.
Thank you, Prof. Mansoor, for breaking it all down so clearly. This has been an incredibly enlightening neurovascular nugget. And for our listeners, you can read more about this at #neurovascular nuggets and check out the link in the show notes. It's a must read.
Indeed it is. Until next time, stay curious and keep learning. This knowledge truly makes a difference in patient lives.
Absolutely. Bye for now, everyone.